Welcome to the Sleepy Pharmacist. This channel shares calm, factual information about medicines and pharmacology. In this video, you'll hear quiet facts about blood pressure medications designed to help you learn gently and fall asleep. You can listen actively or let the information fade into the background as you rest. There is a group of medications called angiotensin-converting enzyme inhibitors that block an enzyme in the body called angiotensin-converting enzyme. Angiotensin-converting enzyme normally converts a substance called angiotensin 1 into angiotensin 2, and angiotensin 2 can cause blood vessels to constrict, so blocking the enzyme reduces the formation of angiotensin 2. Angiotensin 2 is considered a vasoconstrictor, meaning it narrows blood vessels, and when blood vessels narrow, pressure inside them can increase. Blocking the production of angiotensin 2 allows blood vessels to relax, and relaxed blood vessels become wider, a process called vasodilation. Angiotensin-converting enzyme inhibitors also reduce the secretion of a hormone called aldosterone, which causes the body to retain sodium and water, and lower aldosterone levels reduce sodium and water retention. Reduced sodium and water retention leads to lower blood volume, meaning there is less fluid in the circulatory system, which can contribute to lower pressure within the blood vessels. These medications also slow the breakdown of a substance called bradykinin, a peptide that causes blood vessels to dilate, so higher bradykinin levels can contribute to blood vessel relaxation. Higher bradykinin levels are associated with a characteristic side effect in some people, a dry cough that can occur in a portion of people who take these medications. The renin-angiotensin-aldosterone system is a hormonal system in the body that helps regulate blood pressure and fluid balance, and angiotensin-converting enzyme inhibitors act on this system. The renin-angiotensin-aldosterone system involves the kidneys, where specialized cells release a substance called renin in response to low blood pressure or low sodium levels. Renin starts a cascade of chemical reactions in the body that eventually produces angiotensin 2, and angiotensin-converting enzyme inhibitors interrupt this cascade at the conversion step. Captopril was the first angiotensin-converting enzyme inhibitor to receive approval for clinical use and was approved in 1981, representing a new approach to blood pressure medication. Captopril was developed from research on the venom of a Brazilian pit viper, which contained peptides that could inhibit the angiotensin-converting enzyme. A Brazilian scientist named Sergio Ferreira identified these peptides in viper venom and reported that the peptides could lower blood pressure during the 1960s. Scientists at a pharmaceutical company synthesized these peptides in the laboratory, and early versions were peptides that could not be taken by mouth, so researchers worked to create a small molecule that could be taken orally. Captopril was the result of this effort and was designed to be an orally active medication so people could take it as a pill rather than as an injection. British pharmacologist Sir James Black contributed to understanding receptor-based drug design, and his work influenced the development of multiple drug classes. Enalapril was another angiotensin-converting enzyme inhibitor that was approved in 1985, and enalapril is a prodrug that requires conversion in the body to become active. After enalapril is taken, the liver converts it to enalaprilat, which is the active form of the medication, and this conversion happens after the medication is absorbed. Lisinopril was approved in 1987 and, unlike enalapril, does not require liver conversion to become active, remaining active in its original form. Lisinopril is widely prescribed and has been in use for several decades, with many people taking lisinopril on a daily basis. Ramipril was approved in 1991 and, like enalapril, is a prodrug that is converted to its active form in the body. Angiotensin-converting enzyme inhibitors reduce the workload on the heart by lowering vascular resistance, and lower resistance means the heart pumps against less pressure. Captopril has a chemical component called a sulfhydryl group that may contribute to certain side effects, including an alteration in taste. Enalapril, lisinopril, and ramipril do not have this sulfhydryl group, and their chemical structures are slightly different from captopril, which may explain some differences in their side effect profiles. The dry cough associated with angiotensin-converting enzyme inhibitors is associated with bradykinin accumulation, and bradykinin can build up in the lungs, which is thought to trigger the cough reflex. The cough is typically dry and non-productive, meaning no mucus is produced, and the cough can be persistent in some people. Angioedema is an uncommon but potentially serious effect of angiotensin-converting enzyme inhibitors and involves swelling of deeper layers of the skin, which can sometimes affect the airway. Potassium levels in the blood may rise when taking angiotensin-converting enzyme inhibitors because aldosterone suppression reduces potassium excretion, and potassium is normally excreted by the kidneys under aldosterone's influence. First-dose hypotension can occur with angiotensin-converting enzyme inhibitors, and hypotension means low blood pressure, with this effect being more pronounced in people who are volume depleted. Dizziness may occur when taking these medications, and the dizziness is related to the reduction in blood pressure and may be more noticeable when standing up quickly. The development of angiotensin-converting enzyme inhibitors is considered a landmark in cardiovascular pharmacology and represented a new way of targeting hormonal blood pressure regulation, influencing the development of later drug classes. Some angiotensin-converting enzyme inhibitors cross the blood-brain barrier, which is a protective layer that separates the brain from the bloodstream, and drugs that cross this barrier can have central nervous system effects. The brain has its own local renin-angiotensin system that may function partly independently of the system in the rest of the body, and research has examined the effects of blocking this local system. Angiotensin-converting enzyme inhibitors dilate the efferent arteriole of the kidney, which is a small blood vessel leaving the kidney's filtering unit, and this dilation reduces pressure inside the filtering unit. The filtering unit of the kidney is called the glomerulus, and lower pressure inside the glomerulus may reduce the leakage of protein into urine, which has been a subject of research interest. Lisinopril is not metabolized by the liver and is excreted unchanged by the kidneys, meaning liver function generally does not significantly affect lisinopril levels in the body. Fosinapril is an angiotensin-converting enzyme inhibitor with a dual elimination pathway, with both kidney and liver excretion pathways, which can be useful in certain situations. Tissue angiotensin-converting enzyme exists in blood vessel walls and organs in addition to the enzyme circulating in the blood, and some angiotensin-converting enzyme inhibitors penetrate tissues more than others. A misconception about angiotensin-converting enzyme inhibitors is that the cough indicates an allergic reaction, but the cough is a pharmacological effect associated with bradykinin accumulation and is not considered an allergic response. Another misconception is that all blood pressure medications cause the same dry cough, but the dry cough is relatively specific to angiotensin-converting enzyme inhibitors, and other blood pressure medication classes cause cough less frequently. Full blood pressure effects from angiotensin-converting enzyme inhibitors may take several weeks to stabilize, and the medications do not reach their maximum effect immediately, with steady blood pressure reduction developing over time. There is another class of blood pressure medications called angiotensin receptor blockers, sometimes referred to as sartans, and this name comes from the shared suffix used in this drug class. Angiotensin receptor blockers work differently from angiotensin-converting enzyme inhibitors because they block the receptor where angiotensin II acts, which is called the angiotensin II type 1 receptor. Unlike angiotensin-converting enzyme inhibitors, angiotensin receptor blockers do not stop angiotensin II from being formed, and angiotensin II is still produced in the body, but cannot activate its receptor when the receptor is blocked. Angiotensin receptor blockers do not affect the metabolism of bradykinin, so bradykinin levels do not increase with these medications, which helps explain why dry cough is less common with angiotensin receptor blockers. Blocking the angiotensin II type 1 receptor allows blood vessels to relax, and this relaxation leads to vasodilation, with widening of blood vessels reducing pressure within them. Aldosterone release is also reduced when the angiotensin II type 1 receptor is blocked, and lower aldosterone means less sodium and water retention, contributing to the blood pressure lowering effect. The angiotensin II type 2 receptor remains unblocked with these medications, and this receptor may have different effects from the type 1 receptor, with some researchers hypothesizing that leaving the type 2 receptor active may have beneficial effects. Losartan was the first angiotensin receptor blocker to receive approval for clinical use and was approved in 1995, and it was developed through collaborative pharmaceutical research. Valsartan was approved in 1996 and was the second angiotensin receptor blocker to reach the market, becoming widely prescribed over the following years. Irbesartan was approved in 1997, and candesartan followed with approval in 1998, with each new medication in the class providing another option. Olmesartan was approved in 2002, and azilsartan was approved in 2011 as the class continued to expand over more than a decade. Angiotensin receptor blockers were developed as alternatives for people who could not tolerate cough from angiotensin-converting enzyme inhibitors, and the reduced cough was a significant advantage, leading many people to switch for this reason. Losartan has a property not shared by most other angiotensin receptor blockers, as it has a uric acid lowering effect due to interaction with transporters in the kidney. Uric acid is a substance that can accumulate in the blood, and losartan affects how the kidney handles uric acid, with this property being relatively specific to losartan among angiotensin receptor blockers. Losartan is converted to an active metabolite in the body called EXP3174, and this metabolite is more potent and longer acting than losartan itself. Telmisartan has one of the longest half-lives among angiotensin receptor blockers, and half-life refers to the time it takes for drug concentration to decrease by half, with a longer half-life, meaning the drug stays in the body longer. Telmisartan also has partial activity at a receptor involved in metabolic regulation called peroxisome proliferator activated receptor gamma, and this property is not shared by other angiotensin receptor blockers. Several angiotensin receptor blockers are administered as prodrugs, with azilsartan given as azilsartan medoxamil and candesartan given as candesartan kilicetyl. Olmesartan is also administered as a prodrug called olmesartan medoxamil, and these prodrugs are converted to their active forms after absorption, with conversion happening in the gastrointestinal tract or liver. Angiotensin receptor blockers dilate the efferent arteriole of the kidney, similar to the effect of angiotensin-converting enzyme inhibitors, and this dilation reduces pressure inside the glomerulus. Potassium levels may rise when taking angiotensin receptor blockers because aldosterone activity is reduced, and reduced aldosterone means less potassium is excreted by the kidneys. Angiotensin receptor blockers are generally associated with good tolerability, with side effects reported less frequently than with some other classes, and reduced cough is a notable advantage. Angioedema can occur with angiotensin receptor blockers, and it is reported less often than with angiotensin-converting enzyme inhibitors, with the lower incidence possibly related to the lack of bradykinin elevation. Dizziness may occur with angiotensin receptor blockers and is related to the reduction in blood pressure, and it may be noticeable when changing positions. First-dose hypotension is possible with angiotensin receptor blockers and is generally less pronounced than with angiotensin-converting enzyme inhibitors, with the blood pressure drop tending to be more gradual. Some angiotensin receptor blockers cross the blood-brain barrier, and the brain contains angiotensin receptors, with central effects being a topic of research interest. Valsartan was subject to recalls in 2018 due to manufacturing impurity concerns, with impurities identified in batches from certain manufacturers. The impurities found in valsartan were identified as probable carcinogens, and a carcinogen is a substance that may cause cancer, with the discovery leading to widespread concern. Regulatory agencies issued guidance on acceptable impurity levels, and the Food and Drug Administration communicated with the public about the recalls, with impurities also found in some batches of losartan and irbesartan. The contamination crisis led to increased regulatory scrutiny of generic manufacturing, with many generic blood pressure medications manufactured overseas and supply chain vulnerabilities becoming a topic of discussion. Angiotensin receptor blockers emerged as a refinement of renin-angiotensin system blockade and were designed to avoid bradykinin-related effects of angiotensin-converting enzyme inhibitors, representing targeted receptor pharmacology. Losartan was the product of more than a decade of research, and earlier, receptor blocker compounds were peptides that could not be taken orally because they are broken down in the digestive system. Losartan was the first non-peptide angiotensin receptor blocker and could be taken as an oral tablet, representing a significant advancement in drug design. A misconception about angiotensin receptor blockers is that they work identically to angiotensin-converting enzyme inhibitors, and they target different points in the same hormonal system, with related but distinct mechanisms. Another misconception is that angiotensin receptor blockers never cause cough, as cough can occur with these medications, but is substantially less common than with angiotensin-converting enzyme inhibitors. A third misconception is that all angiotensin receptor blockers are interchangeable, as individual drugs in this class have different pharmacokinetic properties and differ in factors such as half-life and metabolism. There is a class of blood pressure medications called beta blockers that block receptors called beta-adrenergic receptors, which respond to adrenaline and noradrenaline. Adrenaline is also known as epinephrine, and noradrenaline is also known as norepinephrine, and these are hormones and neurotransmitters that activate the sympathetic nervous system. There are two main subtypes of beta-adrenergic receptors called beta-1 receptors and beta-2 receptors, and each subtype is found in different locations in the body. Beta-1 receptors are concentrated in cardiac tissue and found primarily in the heart, and activation of beta-1 receptors increases heart rate and the force of contraction. Beta-2 receptors are found in the lungs, blood vessels, and other tissues, and they are present in bronchial smooth muscle, with activation of beta-2 receptors causing bronchial smooth muscle to relax. Blocking beta-1 receptors slows the heart rate and also reduces the force of heart contractions, which decreases the heart's oxygen demand. Blocking beta-1 receptors reduces cardiac output, which is the amount of blood the heart pumps each minute, and lower cardiac output can contribute to lower blood pressure. Beta blockers also reduce renin release from the kidneys because renin release is stimulated by beta-1 receptors in kidney cells, and blocking these receptors generally decreases the amount of renin that is secreted. Some beta blockers are selective for beta-1 receptors and are called cardioselective beta blockers, meaning they preferentially block beta-1 receptors rather than beta-2 receptors, especially at lower doses. Non-selective beta blockers block both beta-1 and beta-2 receptors and do not distinguish between the two subtypes, leading to effects in multiple organ systems. Blocking beta-2 receptors can cause airway constriction because beta-2 receptors normally help keep airways relaxed, and when they are blocked, bronchial smooth muscle may tighten. Some beta blockers also have alpha blocking properties, and alpha receptors are another type of receptor found in blood vessels, with blocking alpha receptors contributing to additional blood vessel dilation. Propranolol was the first clinically successful beta blocker and was developed by Sir James Black in the 1960s, and Sir James Black was a Scottish pharmacologist. Sir James Black received the Nobel Prize in Physiology or Medicine in 1988 and was recognized for his work on drug development, with contributions that influenced multiple areas of pharmacology. Propranolol was approved in 1967 and was a major development in cardiovascular pharmacology, with beta blockers becoming widely used after its introduction. Sir James Black sought to reduce the heart's oxygen demand and aimed to block the effects of adrenaline on the heart, and this concept guided the development of propranolol. Earlier beta blockers had unacceptable side effects, and propranolol was the first to have a profile suitable for widespread clinical use, demonstrating the feasibility of receptor-specific drug design. Metoprolol was approved in 1978 and is a cardioselective beta blocker that preferentially blocks beta-1 receptors. Atenolol was approved in 1981 and, like metoprolol, is cardioselective and preferentially blocks beta-1 receptors. Carvedilol was approved in 1995 and blocks alpha-1, beta-1, and beta-2 receptors, giving it multiple receptor blocking actions. Nebivolol was approved in 2007 and is highly cardioselective, and it also stimulates the release of nitric oxide from blood vessel walls. Nitric oxide is a molecule that causes blood vessels to relax, and releasing nitric oxide contributes to vasodilation, giving nebivolol a distinctive property among beta blockers. Beta blockers slow the sinoatrial node firing rate, and the sinoatrial node is the natural pacemaker of the heart, with slowing this node reducing the resting heart rate. Beta blockers also slow conduction through the atrioventricular node, which transmits electrical signals from the upper chambers to the lower chambers of the heart, and slower conduction affects heart rhythm. Beta blockers reduce the force of ventricular contraction, and the ventricles are the main pumping chambers of the heart, with reduced force, meaning the heart contracts less strongly. Myocardial oxygen consumption decreases with beta blockers, and myocardial refers to the heart muscle, with the heart requiring less oxygen when it beats more slowly and with less force. Lipophilicity describes how well a drug dissolves in fats, and lipophilic drugs cross the blood-brain barrier more readily, affecting whether a beta blocker has central nervous system effects. Propranolol is highly lipophilic and crosses the blood-brain barrier easily, allowing it to have effects in the central nervous system. Metoprolol is moderately lipophilic and crosses the blood-brain barrier to some extent, with intermediate central effects. Atenolol is hydrophilic, meaning the drug dissolves well in water, and it crosses the blood-brain barrier less readily than propranolol. Nadolol is also hydrophilic and does not cross the blood-brain barrier as easily, and hydrophilic beta blockers may cause fewer central nervous system effects. Lipophilic beta blockers are primarily metabolized by the liver, and liver function affects how long these drugs stay in the body. Hydrophilic beta blockers are primarily excreted by the kidneys and are eliminated in urine, and kidney function affects how long these drugs stay in the body. Atenolol may require dose adjustment when kidney function is impaired because the kidneys are responsible for its elimination, and reduced kidney function means the drug stays in the body longer. Propranolol does not typically require dose adjustment based on kidney function because the liver metabolizes propranolol, and kidney impairment generally does not significantly affect its elimination. Fatigue is a commonly reported effect of beta blockers, and the feeling of tiredness may be related to reduced cardiac output or central nervous system effects. Cold extremities may occur when taking beta blockers due to reduced peripheral blood flow, and hands and feet may feel colder than usual. Sleep disturbances have been reported with lipophilic beta blockers, and vivid dreams may occur, with some people reporting nightmares while taking propranolol. Bradycardia is an expected pharmacological effect of beta blockers, and bradycardia means a slow heart rate with the heart beating fewer times each minute. Sexual dysfunction has been reported with beta blockers and is a recognized adverse effect of the class. Sudden discontinuation of beta blockers may lead to rebound effects, with a temporary increase in heart rate and blood pressure after abrupt stopping. Gradual dose reduction is typically recommended when stopping beta blockers, allowing the body to readjust slowly and reducing the risk of rebound effects. Weight gain has been associated with some beta blockers, with the mechanism not entirely clear and reduced metabolic rate possibly playing a role. Depression was historically attributed to beta blockers, but recent analyses have questioned this association, suggesting the link may be weaker than previously believed. Exercise tolerance may be reduced when taking beta blockers because heart rate cannot increase as much during physical activity, limiting the body's ability to respond to exercise demands. Labetalol blocks alpha-1, beta-1, and beta-2 receptors and has combined alpha and beta blocking activity, with beta blockade generally stronger than alpha blockade. When labetalol is taken orally, beta blockade is generally stronger than alpha blockade, and when given intravenously, the balance between alpha and beta effects can differ. Carvedilol also blocks alpha-1, beta-1, and beta-2 receptors and has combined blocking activity, and carvedilol has been studied for additional properties beyond receptor blockade. Carvedilol has been reported to have antioxidant effects that are separate from its receptor blocking actions, and antioxidants neutralize free radicals, with this property studied as a distinguishing feature of carvedilol. Bisoprolol is often described as highly cardioselective among beta blockers, with a strong preference for beta-1 receptors over beta-2 receptors, and cardioselectivity is relative and depends on dose. Cardioselectivity diminishes at higher doses, and even selective beta blockers can begin to block beta-2 receptors at higher doses, meaning selectivity is relative rather than absolute. Some beta blockers partially activate the receptors they block, and this property is called intrinsic sympathomimetic activity, where the drug blocks stronger stimulation while providing mild activation. Pindolol has significant intrinsic sympathomimetic activity and blocks the effects of adrenaline while mildly activating beta receptors, which may result in less slowing of the resting heart rate. Acebutolol has mild intrinsic sympathomimetic activity, and cartiolol also has this property, with penbutolol being another beta blocker with intrinsic sympathomimetic activity. Beta blockers with intrinsic sympathomimetic activity may cause less coldness in the extremities because mild receptor activation can maintain some blood flow to peripheral tissues, and this was considered a potential advantage when these drugs were developed. Beta blockers with intrinsic sympathomimetic activity became less commonly used for some cardiac indications, as evidence suggested differences in benefit for certain conditions, and many commonly used beta blockers today lack this property. Some beta blockers have membrane-stabilizing activity, also called a quinidine-like effect, referring to a local anesthetic-like effect on cell membranes. Propranolol has membrane-stabilizing activity that can stabilize cardiac cell membranes against electrical excitation, and this property is distinct from beta receptor blockade. Membrane-stabilizing activity generally requires concentrations higher than typical clinical use, and at normal doses this effect is not significant, with the clinical relevance of this property debated. Acebutolol and betaxolol also have membrane-stabilizing activity, which is shared by only some beta blockers and is not a defining characteristic of the class. Sotalol is a beta blocker with additional antiarrhythmic properties and has class 3 antiarrhythmic activity, meaning it affects cardiac electrical activity in a specific way. Sotalol prolongs the cardiac action potential, which is the electrical signal that triggers heart muscle contraction, and prolonging it affects the timing of heartbeats. Sotalol prolongs the QT interval on an electrocardiogram, which is a recording of the heart's electrical activity, and the QT interval represents a specific portion of the heartbeat cycle. Sotalol is primarily used for heart rhythm conditions rather than blood pressure, and its antiarrhythmic properties are its main clinical use, and it is hydrophilic and does not cross the blood-brain barrier easily. Esmolol is an ultra-short-acting beta blocker with a half-life of approximately 9 minutes, meaning its effects wear off very quickly. Esmolol is metabolized by esterases in red blood cells, which are enzymes that break down certain chemical bonds, and this metabolism is largely independent of liver or kidney function. Rapid metabolism makes esmolol useful in certain clinical settings because its effects can be quickly adjusted or stopped, and esmolol is administered intravenously rather than orally. Landiolol is an ultra-short-acting beta blocker available in Japan and is described as highly cardioselective, and landiolol is not available in the United States. Metoprolol is metabolized by a liver enzyme called cytochrome P452D6, and genetic variations in this enzyme affect metoprolol levels. Approximately 7 to 10% of some populations are poor metabolizers of cytochrome P452D6, meaning they break down metoprolol more slowly and have higher metoprolol blood levels. Poor metabolizers may experience more pronounced effects from metoprolol because the medication stays in their bodies longer and the same dose produces higher drug concentrations. Carvedilol is also metabolized by cytochrome P452D6, and genetic variations can affect carvedilol levels, with pharmacogenomic testing for beta blockers not yet routine practice. Propranolol is metabolized by multiple liver enzymes, and genetic variations in these enzymes can affect propranolol levels, making its metabolism complex. The beta-1 receptor is encoded by a gene called ADRB1, and variations in this gene may affect how people respond to beta blockers, with research examining associations between gene variants and drug response. Betaxolol is a cardioselective beta blocker used primarily in eye drop form, with eye drops containing betaxolol used for elevated eye pressure and applied directly to the eye. Systemic absorption can occur with beta blocker eye drops, allowing the medication to enter the bloodstream through blood vessels in the eye and cause beta blocker effects throughout the body. Timolol eye drops have caused systemic beta blockade effects, and people using these drops may experience slowed heart rate. Propranolol is reportedly used by some musicians to reduce performance anxiety, as stage fright involves increased adrenaline release, and propranolol can reduce physical symptoms like tremor and rapid heartbeat. Competitive archers and shooters have reportedly used beta blockers because beta blockers can reduce hand tremor, and steadier hands may improve accuracy in precision sports. Beta blockers are restricted in certain competitive sports, and anti-doping organizations prohibit their use in events like archery and shooting as a form of performance enhancement. Propranolol has been studied for effects on fear and memory processes, with research examining propranolol in the context of traumatic memory and how the medication might affect memory reconsolidation. Sir James Black later developed cimetidine after propranolol, and cimetidine was the first histamine H2 blocker, with Sir James Black's career including multiple significant drug discoveries. A misconception about beta blockers is that they are all identical in their effects, when in reality, beta blockers vary significantly in their properties and differ in receptor selectivity, lipophilicity, and additional characteristics. Another misconception is that beta blockers always cause depression, and the association between beta blockers and depression is weaker than historically believed, with recent analyses questioning this connection. A third misconception is that beta blockers can be stopped abruptly without consequence, and sudden discontinuation may cause rebound effects, with gradual dose reduction often used to reduce this risk. There is a class of blood pressure medications called calcium channel blockers that inhibit voltage-gated calcium channels found in cardiac muscle, vascular smooth muscle, and conducting tissue. Calcium entry through these channels triggers muscle contraction, and when calcium enters a muscle cell, it initiates the contraction process, while blocking calcium entry causes muscle relaxation. There are two main subclasses of calcium channel blockers called dihydropyridines and non-dihydropyridines, and these subclasses have different effects on the body. Dihydropyridines primarily affect blood vessels and cause relaxation of vascular smooth muscle, leading to dilation of arteries. Non-dihydropyridines affect both the heart and blood vessels, with effects on cardiac muscle and conducting tissue, and they also cause vascular smooth muscle relaxation. Dihydropyridines include medications such as amlodipine and nifedipine, and these are commonly used calcium channel blockers that are primarily used for their effects on blood vessels. Non-dihydropyridines include diltiazem and verapamil, and these medications affect both the heart and blood vessels, and can slow the heart rate while also dilating blood vessels. L-type calcium channels are the primary target of calcium channel blockers, and the letter L refers to long-lasting current characteristics, with these channels allowing calcium to enter cells for extended periods. Relaxation of vascular smooth muscle reduces peripheral resistance, and peripheral resistance is the resistance blood encounters as it flows through vessels, with lower resistance allowing blood to flow more easily. Coronary arteries can also dilate with calcium channel blockers, and coronary arteries supply blood to the heart muscle, with dilation potentially increasing blood flow to the heart. Verapamil was one of the first calcium channel blockers developed and was discovered in the 1960s, and it was initially studied as a coronary vasodilator. The calcium blocking properties of verapamil were clarified later, as scientists initially did not fully understand its mechanism, and the link to calcium channels was established through later research. German physiologist Albrecht Fleckenstein pioneered calcium antagonist research and demonstrated that calcium entry was essential for cardiac contraction, and his work helped establish the calcium channel blocker class. Verapamil was approved by the Food and Drug Administration in 1981 and was among the early calcium channel blockers available in the United States, and verapamil is still used today. Nifedipine was approved by the Food and Drug Administration in 1981, and it is a dihydropyridine calcium channel blocker that primarily affects blood vessels rather than the heart. Diltiazem was approved by the Food and Drug Administration in 1982, and it is a non-dihydropyridine calcium channel blocker with effects on both the heart and blood vessels. Diltiazem is chemically classified as a benzothiazepine, and this structure differs from dihydropyridines and verapamil, with each class binding to different sites on the calcium channel. Verapamil is chemically classified as a phenylalkylamine, and this structure differs from dihydropyridines, with structural differences helping explain differences in effects. Amlodipine was approved by the Food and Drug Administration in 1992 and became widely prescribed for blood pressure management, and amlodipine is a dihydropyridine calcium channel blocker. Amlodipine has a long half-life of approximately 30 to 50 hours, which is among the longer half-lives for commonly used calcium channel blockers. The long half-life of amlodipine allows once-daily dosing, and the medication remains in the body for extended periods, with blood levels tending to remain relatively stable throughout the day. Dihydropyridines have minimal direct cardiac effects at typical doses and primarily affect blood vessels, and they generally do not directly slow the heart. Reflex tachycardia may occur with dihydropyridine calcium channel blockers, and tachycardia means an increased heart rate, with the body increasing heart rate in response to lowered blood pressure. Amlodipine causes less reflex tachycardia than short-acting nifedipine, and its gradual onset reduces this response, allowing the body more time to adjust to blood pressure changes. Verapamil slows the heart rate through effects on the cardiac conducting system, and it affects the sinoatrial and atrioventricular nodes. Verapamil can also reduce the force of cardiac contraction, and this effect is called negative inotropy. Diltiazem has intermediate effects on the heart and slows the heart rate less than verapamil, and it is often described as having properties between subclasses. Non-dihydropyridines slow conduction through the atrioventricular node, and the atrioventricular node controls electrical signal timing between heart chambers, with slowing conduction affecting heart rhythm. Calcium channel blockers cause arterial dilation to varying degrees, which is a shared effect across the class, and dilation reduces the pressure the heart pumps against. Dihydropyridines are generally stronger vasodilators than non-dihydropyridines, which makes them effective for lowering blood pressure. Venous dilation is minimal with calcium channel blockers, and these medications primarily affect arteries, with veins generally less affected. Calcium channel blockers dilate the afferent arteriole of the kidney, and the afferent arteriole brings blood into the glomerulus, which can increase blood flow into the filtering unit. Peripheral edema is a common effect of dihydropyridine calcium channel blockers, and edema means swelling caused by fluid accumulation, often in the ankles and lower legs. Edema with calcium channel blockers is related to arterial dilation without corresponding venous dilation, and this imbalance can shift fluid into tissues. Fluid can move from capillaries into surrounding tissue, and capillaries connect arteries and veins, with pressure changes causing fluid leakage. Diuretics may not reliably relieve calcium channel blocker-related edema because the swelling is due to fluid redistribution rather than excess total body fluid. Constipation has been reported with verapamil, and verapamil affects smooth muscle, including intestinal smooth muscle. The gut relies on smooth muscle contractions to move food, and reduced contractions can slow stool movement and contribute to constipation. Gingival hyperplasia has been reported with calcium channel blockers, and gingival hyperplasia refers to gum tissue overgrowth. Flushing may occur with calcium channel blockers, and flushing involves warmth and redness of the skin due to blood vessel dilation near the surface. Headache may occur when starting calcium channel blockers, and this is related to blood vessel dilation and often improves with time. Verapamil and diltiazem can slow heart rate further when combined with other heart-slowing medications, and this can increase the risk of conduction abnormalities. Grapefruit juice can increase levels of some calcium channel blockers, and grapefruit compounds inhibit drug metabolizing enzymes, increasing drug absorption. The enzyme affected by grapefruit is cytochrome P453A4, and this enzyme normally breaks down certain calcium channel blockers in the intestine, with inhibition increasing drug levels. Grapefruit juice can substantially increase phenolphthalein exposure, and the degree of increase varies between individuals, with this interaction being well described. Diltiazem is metabolized by cytochrome P453A4 and also inhibits this enzyme, which can increase levels of other drugs metabolized by the same pathway. Verapamil is also metabolized by cytochrome P453A4 and inhibits this enzyme, and this can contribute to drug interactions. Verapamil inhibits a transport protein called P-glycoprotein, which is found in cell membranes and affects how drugs move in and out of cells, influencing how medications can be distributed in the body. By inhibiting P-glycoprotein, verapamil can alter levels of other medications because reduced drug efflux from cells can be associated with higher systemic concentrations and drug interactions. Immediate release nifedipine was associated with adverse cardiovascular outcomes in some studies, and rapid reductions in blood pressure raised safety concerns, with extended release formulations becoming more commonly used. Nifedipine was originally formulated as a capsule intended to be swallowed whole, and some people bit the capsule to achieve faster effects, which caused rapid and sometimes large drops in blood pressure. The controversy over short-acting nifedipine emerged in the 1990s, and clinical studies raised safety concerns about immediate-release formulations, leading to changes in prescribing practices. Extended-release preparations became standard for many cardiovascular uses because these formulations release medication slowly over time and produce more stable blood levels. Some calcium channel blockers use osmotic pump technology for extended release, where water enters the tablet and pushes medication out through a small opening at a controlled rate. The empty tablet shell from osmotic pump formulations may appear intact in stool, which is a known finding and does not indicate treatment failure. Phenolphthalein has high vascular selectivity and affects blood vessels more than the heart, and it is among the more vascular selective dihydropyridines. Nisoldipine absorption is affected by food, and food can significantly alter its absorption and change how much medication enters the bloodstream. Clevidipine is an intravenous dihydropyridine calcium channel blocker that is metabolized by blood esterases that rapidly break down the drug. Clevidipine has an ultra-short half-life of about 1 minute, and its effects stop quickly after infusion ends, making it useful for rapid blood pressure control in monitored settings. Nimodipine is a dihydropyridine with selectivity for cerebral blood vessels, and it crosses the blood-brain barrier and affects brain circulation. Nimodipine has been studied for cerebral vasospasm, which is sudden narrowing of blood vessels that can occur after certain types of brain bleeding. The dihydropyridine class was developed through chemical modifications of nifedipine, and structural changes produced medications with different pharmacologic properties. Amlodipine's commercial success was related to its pharmacokinetic properties, and its long half-life and once-daily dosing contributed to widespread use. A common misconception is that all calcium channel blockers are the same, and dihydropyridines and non-dihydropyridines have distinct pharmacological profiles and clinical effects. Another misconception is that leg swelling from calcium channel blockers indicates heart failure, because the edema is a local vascular effect and is not necessarily due to fluid overload. A third misconception is that calcium channel blockers weaken bones by blocking calcium, because these drugs block calcium channels in muscle cells and do not affect dietary calcium absorption or bone metabolism. Thiazide diuretics are a class of medications that increase urine production and are commonly used for blood pressure treatment. Thiazide diuretics act on the distal convoluted tubule of the nephron, which is the functional unit of the kidney. Thiazides block the sodium chloride cotransporter in the distal convoluted tubule, and this transporter normally reabsorbs sodium and chloride back into the bloodstream. Blocking the sodium chloride cotransporter leaves sodium in the urine, and water follows sodium by osmotic forces, increasing urine output. Blood volume decreases in the short term with thiazide use, and reduced blood volume contributes to lower blood pressure. Long-term blood pressure reduction with thiazides involves vascular effects, and chronic use is associated with reduced vascular resistance, although the exact mechanism is not fully understood. Thiazides increase calcium reabsorption in the kidney, so less calcium is excreted in the urine. Potassium excretion increases with thiazide diuretics, which can lead to low potassium levels in the blood. Magnesium excretion also increases with thiazides, and both potassium and magnesium levels may change during use. Uric acid excretion decreases with thiazides, which can raise blood uric acid levels and contribute to gout risk in susceptible individuals. Chlorothiazide was the first thiazide diuretic approved in 1958, and its development was a landmark in blood pressure pharmacology. Chlorothiazide was developed by a pharmaceutical research team led by Carl Bayer, and the work earned the team the Lasker Award. The Lasker Award is a prestigious medical research prize, sometimes called the American Nobel Prize, and it recognized the significance of thiazide development. Hydrochlorothiazide was approved in 1959 and was more potent than chlorothiazide, becoming one of the most commonly prescribed blood pressure medications. Chlorthalidone is a thiazide-like diuretic with a different chemical structure but a similar mechanism of action, and it acts on the same kidney segment. Chlorthalidone has a longer duration of action than hydrochlorothiazide, with a half-life of about 40 to 60 hours. Hydrochlorothiazide has a shorter half-life of about 6 to 15 hours, and this difference may affect blood pressure control over a full day. Indapamide is another thiazide-like diuretic with additional direct vascular effects, and it has lipophilic properties that influence tissue distribution. Thiazides were among the first effective oral blood pressure medications, and their introduction transformed hypertension treatment. Mercurial diuretics were used before thiazides but had toxicity concerns due to mercury, and thiazides provided a safer alternative. About 5% of filtered sodium is reabsorbed in the distal convoluted tubule, which limits the maximum diuretic effect of thiazides. Loop diuretics act at a different nephron site and remove more sodium, so they are more potent than thiazides, which have a sealing effect. Calcium excretion is reduced by thiazide diuretics, and this may have implications for bone mineral density and calcium balance. Reduced calcium excretion from thiazides may influence kidney stone formation, and many kidney stones contain calcium, so lower urinary calcium can affect stone risk. Potassium loss from thiazides can contribute to hypokalemia, and potassium is essential for normal muscle and nerve function. Low sodium levels can occur with thiazides, a condition called hyponatremia, and this effect can be more common in older adults. Blood pressure reduction from thiazides can decrease cardiac workload because lower blood volume means the heart circulates less fluid. Volume reduction decreases preload on the heart, and preload refers to how much blood fills the heart before contraction, with less preload often associated with reduced cardiac work. Chronic thiazide use is associated with reduced peripheral vascular resistance, and this may involve gradual changes in sodium handling within vessel walls. Direct vascular effects of thiazides have been proposed, and these mechanisms are not fully understood and remain under investigation. Thiazides may increase blood glucose levels, and potassium depletion has been proposed to influence insulin secretion and glucose regulation. Lipid levels may change transiently with thiazides, and cholesterol and triglycerides can rise temporarily and then stabilize. Thiazides can raise uric acid levels, which is relevant for individuals prone to gout. Elevated uric acid from thiazides can trigger gout flares, and uric acid crystals may deposit in joints and cause inflammation. Electrolyte disturbances are a key monitoring issue with thiazides, and potassium, sodium, and magnesium levels can be affected. Increased urination is an expected effect of thiazides, and diuresis reduces blood volume and lowers blood pressure. Dizziness may occur from blood pressure reduction or volume depletion, and symptoms may be more noticeable with position changes. Photosensitivity has been reported with thiazides, and skin may burn more easily with sun exposure. Erectile dysfunction has been reported in some studies of thiazides, and the mechanism is not fully understood. Long-term thiazide use may affect glucose metabolism, and blood sugar levels can increase over time in some individuals. Hydrochlorothiazide has been associated with increased risk of certain skin cancers in observational studies, and regulatory agencies have issued safety communications. The association involves non-melanoma skin cancers such as squamous cell carcinoma and basal cell carcinoma, and ongoing research is evaluating this risk. Thiazide development revolutionized blood pressure treatment in the 1950s, when effective oral options were previously limited. The Framingham Heart Study established elevated blood pressure as a cardiovascular risk factor, and the study began in 1948. Thiazides were first-line blood pressure agents for many years, and large trials compared them with newer drug classes. A large trial compared thiazides with calcium channel blockers and angiotensin-converting enzyme inhibitors, with over 33,000 participants enrolled and results published in 2002. The trial showed thiazides were effective initial therapy, and findings supported continued widespread use. Hydrochlorothiazide became a component of many combination pills, and combination products reduce pill burden and improve adherence. Debate continues about chlorthalidone versus hydrochlorothiazide, and some evidence suggests chlorthalidone provides more consistent blood pressure control due to its longer half-life. Metolazone is a thiazide-like diuretic that can remain effective in advanced kidney impairment, and most thiazides tend to lose effectiveness in this setting. Most thiazides become less effective as kidney function declines because reduced delivery to the distal tubule limits their action. Thiazides were derived from sulfonamide antibiotics, and diuretic properties were discovered during sulfonamide research. Cross-reactivity between sulfonamide antibiotics and thiazides is debated, and current evidence suggests true cross-reactivity appears uncommon. Thiazides can increase lithium levels, and they enhance lithium reabsorption in the kidney, raising the risk of lithium accumulation. Bendroflumethiazide is commonly used in the United Kingdom but rarely in the United States, and prescribing patterns vary by region. A misconception is that thiazides work only by increasing urination, and long-term blood pressure effects also involve vascular mechanisms. Another misconception is that thiazides cause calcium loss, and thiazides reduce urinary calcium excretion and may help preserve calcium. A third misconception is that all diuretics are interchangeable, and different classes act at different nephron sites and have different potencies. Loop diuretics are a class of medications that act on the loop of Henle, and the loop of Henle is a U-shaped nephron segment. Loop diuretics act on the thick ascending limb of the loop of Henle, and this segment normally reabsorbs large amounts of sodium. Loop diuretics block the sodium-potassium chloride cotransporter, and this transporter moves sodium, potassium, and chloride together. The thick ascending limb reabsorbs about 25% of filtered sodium, which contributes to loop diuretics being more potent than thiazides. Blocking the sodium-potassium chloride cotransporter prevents sodium reabsorption, so sodium and water remain in the urine and increase output. Loop diuretics disrupt the medullary concentration gradient, which is required for urine concentration. Loss of the concentration gradient leads to large volumes of dilute urine, which contributes to the strong diuretic effect of loop diuretics. Loop diuretics increase excretion of several electrolytes, including sodium, potassium, chloride, calcium, and magnesium, which distinguishes them from thiazide diuretics. They increase calcium excretion, which is the opposite of thiazides, since thiazides decrease urinary calcium excretion. Loop diuretics also cause venodilation, which means widening of veins and can occur before the diuretic effect after intravenous dosing. Venodilation can reduce fluid congestion by decreasing blood returning to the heart and lowering preload. These medications must reach the tubular fluid to work because they act from inside the kidney tubule. Organic anion transporters secrete loop diuretics into the tubule, which allows the drug to reach its site of action. Furosemide was approved in 1966, and it was developed by a German pharmaceutical company and became widely used worldwide. The name furosemide derives from chemical components in its structure, with furfuryl and sulfomoyl groups contributing to the name. In some countries, furosemide is spelled frusemide, and both names refer to the same medication. Bumetanide was approved in 1983, and it is another loop diuretic with different pharmacologic properties. Bumetanide is about 40 times more potent than furosemide by weight, so smaller doses can produce similar effects. Torsemide was approved in 1993 and has a longer duration of action than furosemide. Ethacrynic acid was approved in 1967 and is chemically distinct and not a sulfonamide derivative. Ethacrynic acid may be useful in severe sulfonamide allergy and can be used when sulfonamide loop diuretics are contraindicated. Loop diuretics are called high-ceiling diuretics because they have a greater maximum diuretic effect than thiazides. The ceiling effect refers to the maximum drug response, and loop diuretics have a higher ceiling than thiazides. Loop diuretics cause rapid and substantial sodium and water excretion, with urine output increasing soon after dosing. They can remain effective in reduced kidney function, which is an advantage over thiazides. Oral furosemide absorption varies widely, with bioavailability ranging from about 10 to 100%. Some individuals absorb very little oral furosemide, while others absorb nearly all of it, and this variability affects clinical response. Bumetanide has more consistent oral absorption than furosemide, with more predictable bioavailability. Torsemide has high and consistent oral bioavailability and is reliably absorbed. Torsemide also has a longer half-life than furosemide, so its effects are sustained longer. Rapid fluid removal reduces preload on the heart, and less filling is associated with reduced cardiac workload. Loop diuretics can cause ototoxicity, which refers to damage to hearing. Ototoxicity is related to effects on ion transport in the inner ear, where similar transport systems exist in the kidney. Risk of ototoxicity increases with rapid intravenous administration, and slower infusion reduces peak levels and risk. Risk also increases with other ototoxic medications, such as certain antibiotics. Ethacrynic acid has a higher ototoxicity risk than other loop diuretics, which limits its routine use. Excessive diuresis can cause volume depletion because too much fluid loss lowers blood volume. Volume depletion can cause hypotension, dizziness, and lightheadedness. Electrolyte abnormalities are a major monitoring concern with loop diuretics, and multiple electrolytes can be affected. Low potassium is common with loop diuretics, and supplementation may be needed. Low magnesium can occur with loop diuretic use, and levels often require monitoring. Low sodium can develop with loop diuretics, and severe hyponatremia can cause serious symptoms. Hearing changes may be temporary or permanent, with some resolving after discontinuation and others persisting. Muscle cramps may result from electrolyte disturbances because electrolyte imbalance affects muscle function. Loop diuretics can raise uric acid and trigger gout attacks. Photosensitivity has been reported with furosemide, and skin may be more sensitive to sunlight. Metabolic alkalosis may occur due to chloride and hydrogen ion loss. Loop diuretics can affect glucose tolerance, and blood sugar control may change. Loop diuretics have a threshold effect, meaning a minimum concentration in the tubule is required for diuresis. Chronic use of loop diuretics can lead to diuretic resistance, where the diuretic effect diminishes as the body adapts. The distal tubule can compensate by increasing sodium reabsorption, which reduces the overall diuretic response. This adaptation is called the braking phenomenon, and higher doses may be required to achieve the same effect. Combining a loop diuretic with a thiazide can overcome resistance by blocking sodium reabsorption at 2 nephron sites. This approach is called sequential nephron blockade and is more potent than either diuretic alone. Loop diuretics were a major advance for treating fluid overload, and severe fluid retention was difficult to manage before their development. Furosemide became one of the most widely used medications worldwide and has been prescribed for decades across many conditions. Furosemide is known by the brand name Lasix, and the name suggests a 6-hour duration of action. Furosemide has been used in horse racing to reduce exercise-induced pulmonary hemorrhage, which is bleeding in the lungs during intense exercise. Regulations on furosemide use in horse racing vary by jurisdiction, with some allowing it and others restricting or banning it. Debate over furosemide in racing involves animal welfare and competitive fairness, and policies have changed over time. A common misconception is that loop diuretics are interchangeable with thiazides, but loop diuretics are much more potent and act at a different nephron site. Another misconception is that loop diuretics help build bone, even though they increase calcium excretion. A third misconception is that higher doses always produce better results. But loop diuretics have a ceiling effect, and side effects increase with dose. Reverend Stephen Hales first measured blood pressure in 1733 by inserting a brass tube into an artery and observing blood rise in a glass column. The blood column rose to over 8 feet, demonstrating the force of blood pressure, and Hales is considered the father of hemodynamics. Hemodynamics is the study of blood flow and pressure in the circulatory system, and Hales's experiment was foundational to this field. The sphygmomanometer was developed in the late 1800s to measure blood pressure using an inflatable cuff. Scipione Riva Rocci invented the modern mercury sphygmomanometer in 1896, and his design became the standard for over a century. Nikolai Korotkov described the sounds used to measure blood pressure in 1905, which are called Korotkov sounds. Before the 1900s, high blood pressure was not considered treatable, and few effective therapies existed. President Franklin D. Roosevelt died of a stroke in 1945 with severely elevated blood pressure, and effective medications were not available during his presidency. Roosevelt's blood pressure reportedly reached 300/190 millimeters of mercury, which are extremely high levels. Doctors had few treatment options for Roosevelt and mainly observed his rising blood pressure. Sodium thiocyanate was an early blood pressure drug used in the early 1900s and had significant toxicity concerns. Veratrum alkaloids were plant-derived blood pressure drugs that caused severe nausea. Early blood pressure medications had severe side effects that limited tolerability. The rice diet was developed by Walter Kempner in the 1940s and was extremely low in sodium, consisting mainly of rice and fruit. Some patients had dramatic blood pressure reductions on the rice diet, but it was difficult to follow. Surgical sympathectomy was used to lower blood pressure by cutting sympathetic nerves. Sympathectomy caused significant side effects, including orthostatic hypotension and fainting. These extreme measures reflected the lack of effective medications at the time. Ganglion blockers were developed in the 1940s and 1950s and blocked nerve transmission at autonomic ganglia. Hexamethonium was an early ganglion blocker that reduced blood pressure by blocking sympathetic outflow. Ganglion blockers caused severe orthostatic hypotension, leading to fainting when standing. Constipation was common because parasympathetic nerves were also blocked. Urinary retention occurred due to impaired bladder signaling. Sexual dysfunction was common because autonomic nerves control sexual function. Ganglion blockers required multiple daily doses due to short duration of action. Patients had to avoid sudden position changes because of severe blood pressure drops. Despite side effects, ganglion blockers improved survival compared to no treatment, proving that blood pressure control was beneficial. Reserpine is derived from the Rauwolfia serpentina plant, which was used in traditional Indian medicine for centuries. Reserpine was isolated from the Rauwolfia plant in 1952, allowing scientists to extract the active compound and enable standardized dosing. Reserpine depletes catecholamines from nerve terminals, including adrenaline, noradrenaline, and dopamine. Depleting catecholamines reduces sympathetic nervous system activity, which normally increases blood pressure. Reserpine effectively lowered blood pressure and became widely used as an early pharmacological breakthrough. Some individuals experienced significant depression with reserpine, which could be severe and limited its use. This depression is linked to depletion of brain catecholamines, which influence mood regulation. Reserpine can cause nasal congestion due to dilation of blood vessels in the nasal passages, producing a blocked sensation. Sedation is another effect, and users may feel drowsy or sleepy. Research on reserpine helped clarify the role of catecholamines in mood and influenced the development of antidepressants. The observation that catecholamine depletion caused depression contributed to the catecholamine hypothesis of mood, which proposed increasing catecholamines as an antidepressant strategy. Reserpine is still available but rarely used today because newer medications are better tolerated. Hydralazine was approved by the Food and Drug Administration in 1953 and is an oral direct vasodilator. Hydralazine relaxes arterial smooth muscle, although the precise mechanism is not fully understood. Hydralazine can cause reflex tachycardia, where heart rate increases in response to lowered blood pressure. Reflex tachycardia is a compensatory physiological response as the body attempts to maintain cardiac output. Hydralazine can cause a lupus-like syndrome with long-term use, which is an autoimmune type reaction. The lupus-like syndrome involves positive anti-nuclear antibodies, which indicate autoimmune activity. Slow acetylators are more susceptible to hydralazine-induced lupus, and acetylation is a liver metabolic pathway. Acetylation speed is genetically determined, and slow acetylators metabolize hydralazine more slowly. Minoxidil is another direct arterial vasodilator developed for blood pressure treatment. Minoxidil was discovered to cause hair growth as a side effect, with patients reporting new hair during treatment. This effect led to topical minoxidil for scalp application, which is widely used for hair loss. Oral minoxidil is reserved for severe or resistant hypertension because its potency and side effects limit routine use. Absorption is the movement of a drug from the gastrointestinal tract into the bloodstream, and oral medications must be absorbed to produce systemic effects, with the rate and extent of absorption varying between drugs. Food can increase, decrease, or have no effect on drug absorption, and the impact depends on the medication and the specific drug-food interaction. Extended-release formulations slow drug absorption to prolong effects, with medication released gradually over time to allow less frequent dosing. Extended-release metoprolol produces steadier blood levels than immediate-release forms, with less fluctuation and more consistent effects. Crushing extended-release tablets destroys the controlled release mechanism, causing the full dose to be released at once and potentially leading to excessive effects. Distribution describes how a drug spreads into body tissues after entering the bloodstream, as drugs circulate in blood and then move into organs and tissues. Lipophilic drugs distribute widely into tissues because they dissolve in fats and enter fatty tissue, which influences how long they remain in the body. Hydrophilic drugs remain mostly in blood and extracellular fluid, with less penetration into fatty tissues, affecting their distribution pattern. Volume of distribution measures how widely a drug disperses in the body, with a large volume indicating extensive tissue penetration, and a small volume indicating confinement to blood and extracellular fluid. Propranolol has a large volume of distribution, spreads widely into tissues, and penetrates the brain. Atenolol has a small volume of distribution, remains mainly in blood and extracellular fluid, and has limited tissue penetration. Protein binding affects the amount of free drug available in the bloodstream, as many drugs bind to blood proteins, and only unbound drug produces pharmacologic effects. Highly protein-bound drugs have less free drug in circulation, with bound drug acting as a reservoir that releases free drug as it is eliminated. Amlodipine is approximately 93% protein-bound, with about 7% free in the blood-producing pharmacologic effects. Other drugs can displace protein-bound drugs, temporarily increasing free drug levels and causing interactions. Metabolism is the chemical transformation of drugs in the body to facilitate elimination, with the liver as the primary metabolic site. Cytochrome P450 enzymes perform most drug metabolism in the liver and convert drugs into metabolites. Cytochrome P453A4 is the most abundant metabolic enzyme and metabolizes many medications, including amlodipine. Grapefruit juice inhibits intestinal cytochrome P453A4, increasing systemic drug levels by reducing intestinal metabolism. Prodrugs require metabolic activation and are administered in inactive form, with the body converting them to active compounds. Enalapril is converted to enalaprilat by liver enzymes, and enalaprilat is the active form after absorption. Lisinopril is not a prodrug and is active without metabolic conversion. Elimination is the removal of drug from the body, with drugs cleared by the kidneys or liver depending on their properties. Renal elimination involves excretion into urine, with the kidneys filtering the drug from blood and removing it during urination. Hepatic elimination involves metabolism and biliary excretion, with the liver processing the drug and excreting it into the intestines via bile. Half-life is the time required for drug concentration to decrease by half, with concentration continuing to halve at each interval. Drugs with long half-lives can often be dosed once daily and maintain relatively stable blood levels. Drugs with short half-lives may require multiple daily doses to maintain therapeutic levels. Kidney impairment prolongs elimination of renally cleared drugs, causing accumulation and longer persistence in the body. Liver impairment prolongs elimination of hepatically metabolized drugs, which can also cause accumulation. Steady state occurs when drug intake equals drug elimination, and average blood levels remain constant with fluctuations around this average. Approximately 5 half-lives are needed to reach steady state as drug levels accumulate with each dose. Amlodipine requires 7 to 10 days to reach steady state due to its long half-life, with full effects developing gradually. Furosemide reaches steady state within about 10 hours because of its short half-life, with effects appearing quickly. Evaluating a new amlodipine dose requires several days because full response develops gradually. Pharmacokinetic interactions alter drug absorption, distribution, metabolism, or elimination, changing blood levels and potentially increasing or decreasing effects. Pharmacodynamic interactions alter drug effects without changing levels, and effects may be additive, synergistic, or antagonistic. Rifampin induces cytochrome P453A4, increasing enzyme activity and clearing metabolized drugs faster. Amlodipine levels decrease when taken with rifampin due to increased metabolism, which may reduce therapeutic effects. Non-steroidal anti-inflammatory drugs can reduce antihypertensive effectiveness by causing sodium retention and vasoconstriction, counteracting blood pressure lowering. Combining angiotensin converting enzyme inhibitors with potassium-sparing diuretics increases the risk of hyperkalemia because both raise potassium levels and dangerous elevations can occur. Loop diuretics and thiazides can increase lithium levels in the blood because lithium is eliminated by the kidneys, and sodium loss from diuretics can increase lithium reabsorption. Beta blockers and non-dihydropyridine calcium channel blockers can together slow the heart rate excessively because both classes reduce heart rate, and combined use requires careful monitoring. The kidney has a local renin-angiotensin system that can operate independently of circulating hormones, with angiotensin produced within kidney tissue. The brain contains a local renin-angiotensin system where angiotensin is produced within brain tissue, and this system has been studied for potential effects on brain function. The heart also contains a local renin-angiotensin system, and angiotensin produced within cardiac tissue may influence heart structure and function over time. Local renin-angiotensin systems can function independently of the circulating system, so blocking circulating hormones may not fully block local effects, and this remains an active research area. Adipose tissue also exhibits local renin-angiotensin activity, and this system in fat tissue may have metabolic implications. Aldosterone has effects beyond sodium and potassium regulation and may contribute to fibrosis in the heart and blood vessels, where fibrosis refers to excess scar-like tissue formation. Spironolactone was originally developed as a diuretic and blocks the mineralocorticoid receptor that aldosterone activates. Spironolactone blocks aldosterone effects in the kidney, increasing sodium excretion and promoting potassium retention, and it is classified as a potassium-sparing diuretic. Spironolactone has hormonal effects beyond diuresis and can bind androgen and progesterone receptors, leading to endocrine-related adverse effects. Gynecomastia can occur with spironolactone use and is breast tissue enlargement in males related to hormonal receptor binding. Hormonal side effects led to development of eplerenone, which is more selective for the mineralocorticoid receptor and has fewer endocrine side effects. Eplerenone causes less gynecomastia than spironolactone because greater receptor selectivity reduces binding to other hormone receptors, improving tolerability for some individuals. Spironolactone is used for hormonal indications unrelated to blood pressure, with anti-androgen effects useful in certain conditions and multiple clinical applications. All angiotensin converting enzyme inhibitors end with the suffix -pril, which identifies the class and includes examples such as lisinopril, enalapril, and ramipril. All angiotensin receptor blockers end with the suffix -sartan, identifying the class with examples such as losartan, valsartan, and irbesartan. Beta blockers typically end with the suffix -olol, which helps identify the class, with examples including metoprolol, atenolol, and propranolol. Dihydropyridine calcium channel blockers typically end with the suffix -dipine, identifying the subclass with examples such as amlodipine, nifedipine, and felodipine. Drug naming follows conventions set by international naming councils, with generic names assigned by official organizations, including the United States Adopted Names Council in the United States. Losartan is available combined with hydrochlorothiazide in a single tablet, combining an angiotensin receptor blocker with a thiazide diuretic to provide two blood pressure lowering mechanisms. Some combination products include 3 medications in one pill to address blood pressure through multiple pathways and simplify medication regimens. Polypills containing blood pressure and other cardiovascular medications have been studied to simplify prevention by addressing multiple risk factors with a single pill. The polypill approach has been evaluated in clinical trials to determine whether combining medications improves outcomes, and the concept remains under investigation. Topical timolol is used for certain skin lesions, and this use is unrelated to blood pressure treatment, demonstrating applications beyond its original purpose. Timolol eye drops were developed for elevated eye pressure and reduce intraocular pressure when applied directly as ophthalmic drops. Systemic absorption of timolol eye drops can affect blood pressure because the drug enters the bloodstream through ocular blood vessels and can cause systemic beta blocker effects. People using timolol eye drops may experience slowed heart rate because beta blockade can occur despite topical administration, demonstrating systemic absorption from topical use. Many generic blood pressure medications are manufactured in India and China, which have large pharmaceutical industries supplying medications worldwide. Supply chain vulnerabilities became a policy topic after the valsartan recalls, as contamination highlighted reliance on overseas manufacturing and raised concerns about quality control and oversight. Blood pressure medication shortages occurred during the valsartan recall period, affecting many patients and making alternative supplies challenging to obtain. The Food and Drug Administration established acceptable impurity limits after the valsartan crisis, with standards defining permissible contamination levels that manufacturers must meet. Regulatory scrutiny of generic manufacturing increased after contamination events, with inspections and oversight enhanced to prevent similar incidents. A third beta receptor subtype is called the beta-3 receptor, and these receptors are located primarily in adipose tissue, which is body fat. Beta-3 receptors influence fat metabolism and thermogenesis, which is heat production by the body, and activation can increase energy expenditure. No approved beta blocker selectively targets beta-3 receptors, as current medications target beta-1 and beta-2 receptors, while beta-3 selective drugs remain under research. Celiprolol has partial beta-2 agonist activity, meaning it mildly activates beta-2 receptors, while blocking beta-1 receptors, which may cause mild bronchodilation. Bronchodilation is widening of the airways, and beta-2 receptor activation in the lungs causes bronchodilation, so celiprolol's partial activation may help maintain airway openness. Celiprolol is available in Europe but not in the United States, and regulatory approvals vary by country, so available beta blockers differ by region. The vasodilatory effect of nebivolol may depend on genetic factors, and not all individuals experience the same degree of vasodilation, with genetic variation potentially influencing response. Nebivolol-induced vasodilation varies among individuals, and some people have a stronger response than others, with mechanisms underlying this variability still under investigation. Pharmacogenomic testing examines how genetic variation affects drug response, and testing can identify individuals who may respond differently to medications, a field known as personalized medicine. Pharmacogenomic testing for beta blockers is not routine clinical practice, as testing exists but is not widely implemented, and additional evidence is needed to establish clinical utility. The beta-1 receptor is encoded by the ADRB1 gene, and genetic variants exist in the population that may influence beta blocker response. Certain ADRB1 variants have been associated with differences in beta blocker response, with some variants predicting altered therapeutic or adverse effects, and research remains ongoing. Sir James Black's work demonstrated the value of receptor-specific drug design, showing that targeting defined receptors produced effective medications and influenced pharmaceutical development for decades. Black applied receptor theory to practical drug development, with receptor theory explaining drug interactions with specific proteins and guiding creation of new therapeutic agents. The development of beta blockers transformed cardiovascular disease management, creating a new therapeutic class that has been used by millions of patients since its introduction. Beta blockers became one of the most widely prescribed cardiovascular drug classes, used for multiple indications, with many agents developed within the class. Each new antihypertensive class provided alternatives for people intolerant of existing medications, allowing individualized therapy selection. Combination therapy for hypertension became common practice, as using multiple medications can improve blood pressure control through synergistic mechanisms. Modern hypertension guidelines incorporate multiple drug classes, with recommendations varying based on patient characteristics and comorbidities, and treatment selection individualized. The Framingham Heart Study began in 1948 and is one of the longest-running cohort studies, following participants from Framingham, Massachusetts across generations. Framingham identified elevated blood pressure as a major cardiovascular risk factor, with higher blood pressure predicting heart disease and stroke, shaping clinical practice. The study contributed to the concept of cardiovascular risk factors, with blood pressure joining cholesterol and smoking as key predictors of cardiovascular disease. Multiple generations of participants have been followed, with descendants of original participants enrolled to study hereditary risk patterns. Framingham findings influenced public health recommendations for decades, supporting lifestyle and pharmacologic interventions and having a major impact on cardiovascular medicine. Blood pressure measurement remains a core component of medical evaluation, and the basic auscultatory technique has changed little since Korotkov's description. Electronic blood pressure monitors are widely available and use sensors rather than auscultation, enabling home blood pressure measurement. Home blood pressure monitoring provides information beyond clinic readings, as blood pressure varies over time, and repeated measurements improve assessment accuracy. White coat hypertension refers to elevated readings in clinical settings where some individuals have higher office measurements than home readings.